Hello, can you guys hear me? My name is Ibrahim. I'll be presenting the topic today. If anyone can just drop in chat, I just turn on their mic. I'd appreciate it. Wonderful. We'll just wait for another 2 to 5 minutes. Then we'll go ahead and we'll make a start. So hopefully it won't keep you guys too long and can finish on time or before time. All right. Hello, everyone. Once again, my name is Ebrahim. I'm going to be doing the presentation today on parathyroid and calcium disorders. Let me try to make this full screen. All right, can everyone see my full screen? Oh, there we go. I just can't tell if it's working because MedAll doesn't let me see the chat and the full screen at the same time. So if when I do this, I assume you can see the PowerPoint in presentation mode, front and back. And when I do that, it stops. Can someone just confirm, or they just sound like I'm going crazy? So if you just unmute yourself or drop in the chat, that'd be great. All right. And did you see it go to? Okay, wonderful. Perfect then. And can we just confirm, is everyone here a final year student? Do we have any doctors? Do we have any year 4, year 3 students? From what I understand, it's mainly year 5s, but if there's anyone who's not a year 5 or is a year 5, just confirm. I'll have an idea to on how to cater the teaching. So go and just type away. All final year, 4th year, final year. All right. All right, then I'll keep it to around that level, mainly final years. We've got a 4th year here as well. All right, guys, that's perfect. Once it goes back to presentation mode, unfortunately, I'm not going to be able to see the chat. We will have a moderator joining shortly, but I don't want to delay everyone. I'm sure everyone's very busy. So I'll get a start to it. if there's any issues, just unmute yourselves and just give me a shout. I'll look through the chat at that point. And if not, we just continue going, and every 5-10 slides, so I'll just drop back, looking at the chat, see if there's any questions or so. Feel free to interrupt me at any point if you have a question, or if not being clear, if there's any connection issues, sharing screen issues, etc. Just interrupt me. I'm more than happy to be interrupted. And if there's anything that's not so urgent and you think you're not really that eager to know at the moment, just drop it in the chat, and I'll make sure that every query in the chat is also answered by the end, which hopefully will be before 11. I'll try and make it a bit faster. So today I'm going to be talking about parathyroid and calcium disorders. I'll be going through the aims and objectives shortly, but realistically, what I want is I'm not really trying to, drill home every single concept of parathyroid and calcium disorders. It's obviously quite a vast subject to discuss, especially in just 1 hour. What I really want to do is give everyone here a strong foundation of how to really think about things and to really understand what's going on. Right? I'm not here to drill the nitty-gritty and the niche things in, but at the end of today, when you do read a textbook or you do read a question, you should be able to visualize and understand what it's asking of you and the physiology of what you should be knowing. So that's really what I want to really drill the basics down really well for you guys. So as for the aims, it's mainly talking about parathyroid physiology, identification and management of parathyroid and calcium disorders, and for you to apply this knowledge to clinical scenarios. We've got quite a few objectives here, but realistically, all we're talking about is hyperparathyroidism, hypoparathyroidism, and hypercalcemia malignancy, and pretty much everything you need to know about it as a medical student, and very soon as well as a doctor, right? So I've tried to make things a lot more clinical based for you guys, because you are all going to be doctors very soon, and this is really where your learning is going to be put to use. Can I get anyone to interact and potentially read the first clinical vignette? So this whole thing's going to be quite interactive. I'd really appreciate if, oh, is that gone? It's back. Oh, it's not back. Is it back for you guys? There you go. It's going to be quite interactive. I'd really appreciate if someone could unmute themselves and read it out. You're not going to have to answer anything, I promise. We'll get to that at the very end after I finish teaching. But is there anyone brave enough to unmute over here today? Oh, can you? Are you not? Oh, can you not? Never mind then. Oh, well, that's okay then. I'll just read through it. You should be able to see this now. So so you're clocking the AMU, which is on the acute take, and you've got 2 patients waiting for you to see. The first patient is a 47-year-old woman. She recently underwent a thyroidectomy due to thyroid cancer, and she complains of cramps and muscle spasms. You take a history from the patient, you do a clinical exam. The patient has a positive chopstick sign, and the nurse reports spasms of the patient's hand while she was checking the vitals. That's your first patient. And at the end of the teaching, we want to basically answer the 3 questions below, which is the suspected diagnosis, the tests that we'd like to order, and our primary management. So this is the first patient that we've seen. The second one is a 55-year-old woman complaining of generalized weakness and bone pain. She's got a history of frequent kidney stones and depression. She's also recently started taking Movicol and Senna, which are both laxatives, which means that she's also recently got some constipation going on. So let's talk about parathyroid physiology. So this is a very succinct image, but really is a very, very good image to take home with you at the end of today. It has pretty much everything you need to know about parathyroid physiology and can really explain everything about hyper and hypoparathyroidism for you. So let's change this to a laser pointer. There, so you should see a laser pointer now. So these 4 small things here are your rice grain-sized parathyroid glands, and these are pretty much the topic of the lecture today. And they secrete parathyroid hormone, right? So that's PTH that these small 4 glands are secreting. So these act in 3 main ways but they mainly affect they have two areas that they mainly affect. So you can see it goes down here to your bones, increase the osteoclast activity, and because of that, you have increased calcium absorption from your bones. That's one way parathyroid hormone makes your calcium go up. The second way is it makes your kidney reabsorb the calcium it was going to secrete, right? So your kidney normally secretes your calcium out via urine, and parathyroid hormone acts in your kidneys and increase the reabsorption of that calcium. So that's your second way. And then the third way is via the kidneys, it actually leads to vitamin D to be activated. And the vitamin D then goes and acts on increasing your intestinal absorption of calcium. So that's the third way in which it increases your calcium. So you can see all three of these mechanisms really of parathyroid hormone lead to increased serum calcium. This provides negative feedback and reduces the amount of PTH being secreted. Now, just speaking about this way, the exact opposite thing. So decreased serum calcium here is what's going to stimulate the parathyroid glands to secrete parathyroid hormone, and that really increases the cycle all over again. So you can see this is a feedback loop which really ensures calcium homeostasis in the body. And a very easy way to remember what they do is, so parathyroid hormone increases more parathyroid hormone, more calcium, less parathyroid hormone, less calcium. And that's a very easy way for you to remember what does what. And wherever your parathyroid hormone and calcium is, your phosphate does the opposite thing. So if you have high parathyroid hormone, then you've got high calcium, you'll get low phosphate as a result of it. Obviously, I'm really simplifying it, but it's an easy way for you to remember what really goes on physiology-wise. So now in a very, very simple manner, what is hypoparathyroidism? It's pretty much self-explanatory. It's hypoparathyroidism. So hyposecretion of parathyroid by the parathyroid hormone by the parathyroid gland. And the most common cause, as was in our first patient, if you recall, is the removal of the parathyroid glands, which is commonly happening during thyroid or parathyroid surgeries. And you can also have hypoparathyroidism from autoimmune conditions or genetic conditions, but a vast majority, all your questions and most of your patients are also going to be due to removal of the parathyroid glands. So let's talk about the pathophysiology, right? So you have any cause that causes it, but you're going to have in hypoparathyroidism, decreased gland function, decreased parathyroid hormone levels, decreased calcium due to all three of the mechanisms we just spoke about. Your blood calcium goes down, and now you have muscular hyperirritability. How do we get hyperirritability of your muscles? Is because calcium essentially acts as it stabilizes the resting membrane potential in your cells. So it's sort of like having a class of say second graders, and if there's no one there looking after them, if there's no teacher in the class, for example, things really do go haywire. At least that's how it was for me. And everything just hyperirritable. You get someone in to look after them, someone there to stay in the class, and it sets a better tone or order in the classroom. And that's pretty much what happens in your body when your calcium levels go down. Everything goes haywire. Everything is hyperirritable, hyperexcitability, and there's hyperexcitability of your muscles. But why is that a bad thing? Can anyone tell me why do we care? Why are we having this talk? Why does it matter if you have muscular hyperirritability? You can drop it in chat since you can't actually speak. So what's something bad that can happen? What do we not want? What are we looking out for? Anything of that sort? Oh, it's still working, yeah. What can be a bad thing due to low calcium? Arrhythmias, yes. So the muscular hyperirritability can happen in many ways, right? So your brain, you can have seizures because of muscular hyperirritability. You can have arrhythmias because of myocardium having hyperirritability. Everything's just working too fast. So your neurons are firing too much, you start having a seizure. Your heart's contracting too fast and it goes into an arrhythmia. And something that a lot of people forget about, and I would urge you to remember because it's going to have real world consequences, is you can also have airway spasms, right? And that's very important because the A of your A2E is your airway. If you have an airway spasm, that is an emergency. You need ITU there. So here you go. So airway spasms, cardiac arrhythmias, and seizures. So if a very easy and good take-home message is if you have a patient with hypocalcemia or suspected hypocalcemia, and they're starting to struggle with their breathing, you need to be worried. You need to go. You need to get your senior. You need to get ITU. You need to get things going, because that would be obviously something to really worry about. So let's talk about the signs and symptoms of hypocalcemia. So we've spoken about that. We've spoken about that. Now, what most of your patients are going to come in and say is that they've got tingling of extremities, tingling of their fingers, they've got muscle cramps, which are all quite non-specific symptoms. But something that can be some signs that are quite specific are chopstick sign and trousseau sign. And of the two, trousseau sign is more specific for hypercalcemia. So keep in mind, these aren't always elicited. These are only in severe hypercalcemia, but nonetheless are very important signs to keep in mind. So the first one is positive chopstick sign. Also keep in mind, these signs are quite subtle. They can be quite, you have to be really concentrating to elicit them and tell that you're able to elicit them. So I'll just give you guys a quick almost a demonstration of, can you guys see my picture? Yeah. Demonstration of how to elicit it. So for a patient, you're going to be looking at the zygomatic process or cheekbone right here. You're going to go just below it, and you should be able to feel your parotid gland, which is underneath, which is where your facial nerve is running, and that's what you're trying to tap to show the hyperirritability that you will see in hypocalcemia. So you essentially tap like so for your patient, and as you can tell, you tell the patient to relax and you do this. For me, nothing's happening because I don't have hypercalcemia. But this is what you'd tend to see, which is again a very subtle sign. You'd see a twitch of the facial muscles to where you are tapping, which is when you'd have a positive chopstick sign, which is as so in the slide. So facial muscle twitch after the facial nerve is slightly tapped 1 centimeter below the zygomatic process, which is right here. And then you've got the positive trousseau sign, which is, it's unlikely for you to see. Usually it would be the nurses checking it, but you can see it if you're at a GP practice. Regardless, this is the more specific sign, something to to be aware of. Again, this is also a very subtle sign. So as the blood pressure cuff tightens, you're going to see flexion of the wrist joint and the metacarpophalangeal joints. So it's going to be something like this. Okay, it's going to be quite subtle. It's not going to be like a focal seizure. You're going to see rhythmic jerking movement. It's going to be very subtle movement, just like that. But if you know what you're looking for, you'll be able to see it, or the nurse might tell you that this is what they saw. But again, this is in severe hypercalcemia, so you might not always see it. So again, here, the blood pressure cuff applies pressure on the brachial nerve, causing it to fire. It's again hyperirritability, and it causes flexion of the wrist and metacarpophalangeal joints. So investigations and treatment. These are rather straightforward. You're going to check your parathyroid hormone, you're going to check your calcium, you're going to check your phosphate, you're going to check magnesium as well, because hypomagnesemia can cause hypoparathyroidism. You check TFTs and ACTH to look for other causes, so adrenal and thyroid causes. ECG for QT interval, you can have a prolonged QT interval in hypocalcemia. So that's something to keep in mind. Hypocalcemia will prolong your QT interval. Hypercalcemia will shorten your QT interval. And then you can have imaging tests for localization, evaluating bone density and risk of fractures, but that's something you really do in the take when you start off as a doctor. So the management for hypercalcemia, as one would quite easily tell, is to replace the calcium initially. So if the calcium levels are below 1.88 millimoles per liter, you give IV calcium gluconate. And something, well, as I said earlier, to really keep in mind is mechanical ventilation can become necessary in a patient who's developing respiratory distress. So please, please, please take this message home and keep that in mind. You will need to escalate a patient with the respiratory distress when they have hypercalcemia as well. So that would be our entire first patient that we saw. That's hypoparathyroidism and hypocalcemia that comes with it. Do we have any questions so far about hypoparathyroidism or hypocalcemia? I'll just give you guys a couple seconds. Just try to process everything we spoke about. So the etiology, the physiology, pathophysiology, and then the investigations and management and things to keep in mind. Anything at all, anything that wasn't clear, just drop in the chat, and then we're going to move on to hyperparathyroidism. All right, I'll take that as yes. All right, wonderful. All clear so far. Appreciate that. Let's see, this should have come back. Yeah, it's come back. There we go. So we're going to move on to hyperparathyroidism, which again is very self-explanatory, pretty much from the name. Hyperparathyroidism, hypersecretion of parathyroid hormone by the parathyroid glands. I mean, I wish you guys could unmute, but that's okay. Let's go there then. So there's three main types of hyperparathyroidism. So you have primary, secondary, and tertiary. It's quite important that you really understand and are able to differentiate between the main types once you've got the blood results back and once you have a good history from the patient. So once again, any questions whatsoever over here, just drop in the chat and I'll be happy to clarify. But there's an important concept I want you to take home with you. So in primary hyperparathyroidism, the parathyroid gland itself is just making the parathyroid hormone, and this is now causing the effects further downstream. So it's primary, it's from the parathyroid gland itself. In the parathyroid gland, this normally happens because of parathyroid adenoma, and that's just having autonomous, it means it's pretty much just having its own function. It's not listening to the feedback it gets from the increased or decreased calcium levels and just really sending things all the way up. It's almost always a parathyroid adenoma. That's primary hyperparathyroidism, so it's from the parathyroid gland itself. Then obviously you've got secondary hyperparathyroidism, and this is when there is hypocalcemia further downstream that's always stimulating the parathyroid hormones to secrete, so parathyroid glands to secrete parathyroid hormone. This can happen in the kidney. So once again, going back to our physiology that we remember, we said that there's three main mechanisms through which the parathyroid hormone acts and increases calcium levels. And if you remember, only one of those were bones. The other two were essentially kidney. So the kidney gave the vitamin D to act on the intestine and cause dietary absorption of calcium. And the kidney also reabsorbed the calcium instead of secreting it. So if your kidneys aren't working that well, and you take away two of these three mechanisms, it quite obviously is going to cause hypocalcemia. You can't just keep degrading your bones and taking all the calcium from there and not taking any of the calcium you eat, while simultaneously the calcium that you take from the bones, you are urinating that away as well. So you're going to end up in this chronic state of hypocalcemia. You end up in this chronic state of hypocalcemia, you keep stimulating the parathyroid glands, who can't really do much because whatever it's trying to do downstream isn't working. Right, and you'll see what this means for the body in a longer term picture. But I hope that overall makes sense with the physiology and pathophysiology side of things. Something else that makes things worse is we've also said earlier that your calcium and phosphate kind of stay at opposite levels, and this chronic hypocalcemia and hyperphosphatemia causes further hypocalcemia because these high levels of phosphate bind to the free calcium levels, reducing the calcium that your body can use as well. So with the long-term secondary hyperparathyroidism, your parathyroid glands have just been continuously stimulated by these low calcium levels, that you sort of have this autonomous parathyroid secretion. Now your body just says, forget about that, the low calcium, high calcium, doesn't matter. At the end of the day, we've just been producing so much parathyroid hormone, we're just going to keep doing it. And your body just produces a ridiculous amount of parathyroid hormone, which is usually due to parathyroid hyperplasia from continuously producing the hormone over so many years. And this now starts resulting in hypercalcemia because you've just got ridiculous levels of parathyroid hormone. And from this chronic bone degradation, you start getting your calcium levels high in tertiary parathyroid, in tertiary hyperparathyroidism. We'll get to this slide in just a second. So if you look at the blood results that you'd see in these three types of hyperparathyroidism, so in primary, it's very straightforward. You've got this adenoma making parathyroid hormone. It pushes the calcium up, pushes the phosphate down, or keeps it normal, and you have a high ALP from obviously the from acting on the bone. It's going to be high throughout. Secondary, you get this high parathyroid hormone, but that's secondary because of the low calcium. If it's normal, it would be inappropriately normal because you've got a high parathyroid hormone, and your phosphate levels are going to go down because it goes to the opposite of however your parathyroid hormone is. Now, you see in tertiary hyperparathyroidism, you've got really, really high parathyroid hormone because of chronic stimulation from the secondary hyperparathyroidism. And you've got low phosphate here as well and a high ALP. So I hope this kind of makes sense from the physiology and pathophysiology point of view. You can kind of see how we come to the primary, secondary, tertiary of hyperparathyroidism. We'll get to this in just a second. Any questions so far? Just keep dropping them in the chat. I'm just taking a look now. I assume everything's clear so far, but feel free to drop anything in the chat, even from previous topics at any point. So now talking about familial hypocalciuric hypercalcemia. Once again, the name pretty much says everything that we need to know. Familial, so it's genetic, hypocalciuric, so low calcium in urine, hypercalcemia, high calcium in blood. So it's a genetic condition in which you have low calcium in your urine and high calcium in your blood. And this is something you always look out for when you have hyperparathyroidism. You just want to make sure it's not this that you're looking at. So how do you really make a difference? Is because in hyperparathyroidism, you're going to have usually normal to high calcium output in your urine, whereas this is obviously hypocalciuric. So you have low calcium output in your urine. And this condition is pretty much always benign. The patient's also usually asymptomatic, so it'd be a coincidental finding that you do bloods, you find high calcium, then the first thing you do is parathyroid, you find hyperthyroid, and you take things from there. But this is a benign condition, no treatment is required, and this is why you're always going to do a urine calcium level when you've got a patient with suspected hyperparathyroidism. So signs and symptoms, I'm sure we've all heard this sentence being thrown around for hypercalcemia, and it is a very good way to remember it. So it's stones, thrones, bones, groans, and psychiatric overtones. It really covers all of these non-specific symptoms we get for hypercalcemia, which is what you'll see in hyperparathyroidism. So stones is renal stones because it's due to hypercalciuria. You've got thrones for toilet, so frequent urination and constipation. These patients can frequently also be quite dry. So you'll have dry mucous membranes, you'll have poor radial pulse volume while assessing such patients. Bones, they can have bone pain, non-specific muscle pain as well. They can just have general fatigue. Groans as well, so groans would be the constipation that they get. They just generally feel unwell, they feel weak from having these high calcium levels. And psychiatric overtones, they can complain of the symptoms of depression, of confusion. You can really tell that this is quite a stark difference to hypoparathyroidism, where you have muscular hyperirritability, and you've got all these heightened symptoms of things really just being hyperirritable with the low calcium levels. You can see with these high calcium levels and the really increasing the resting membrane potential, it's really hard to actually get any sort of neuronal activation, which is why you've got these symptoms like depression, confusion, constipation, weakness, fatigue, and you can really quite easily draw these stark differences, even though both I can appreciate both of these conditions have really vague presenting complaints and symptoms. So talking about management, we're going to get all pretty much the same tests, and we're going to throw in our 24-hour urinary calcium as well. Not mentioned here, but you also need to be getting the ECG as we discussed. So the QT prolongation and calcium levels are inversely proportional. So you're going to see a high QT prolongation, hypocalcemia, decreased QT prolongation in hypercalcemia. So the management for the types of hyperparathyroidism are different, which is why it's important to be able to differentiate between them. Primary hyperparathyroidism, the first line is a total parathyroidectomy, especially for all symptomatic patients. There are a few guidelines which aren't really that important on patients who don't really require a total parathyroidectomy. It's about patients who are above the age of 45, the calcium levels are less than 0.25 above the limit, above the upper limit of normal. They aren't symptomatic as well, but anyone who's symptomatic requires surgery. Very, very, very important. You might see this in the ENT ward as well once you start working. You need to ensure all the patients who are going to have a parathyroidectomy have their vitamin D replaced prior to the procedure. Why is this? It's very interesting. It's called hungry bone syndrome. So essentially, what happens is once you've taken out these parathyroid glands, this overproduction of parathyroid hormone, you need to remember that what had been happening was this chronic bone demineralization. Once you stop causing this bone demineralization, your body is quite happy, it's fixed, it's healthy again, and it tries to immediately remineralize and fix up all this bone that has been lost over the last few weeks, months, etc. And what happens is it just starts using all the calcium that you have available to fix all of your bones, and that's what's called hungry bone syndrome. You start getting hypocalcemia, which can be symptomatic and can be quite severe. So how does it all tie into the vitamin D? As long as you have vitamin D available, you can always reabsorb that calcium from your diet. So again, it all ties back to the first picture we saw of um, parathyroid hormone acting on your kidney and that acting on your intestine and allowing dietary calcium to be absorbed. And as long as you've got enough vitamin D, you can almost your body can sort of counteract or fight with the hungry bone syndrome and replace the calcium that's being absorbed by the bones. Whereas if your vitamin D is low, you now need to replace the vitamin D at a point where your body is already suffering for calcium. So it's kind of like fighting an uphill battle. Best practice is replace the vitamin D preoperatively and you minimize complications in your patients. So that's something to keep in mind. That's hungry bone syndrome. It's again a very practical, real world use of this topic. Then that's just for primary hyperparathyroidism. Then you've got secondary and tertiary. So as we've established, most of these patients will have known chronic kidney disease. You're going to restrict the amount of dietary phosphorus they can have. Again, keep in mind that the dietary phosphorus can worsen the hypocalcemia they had because it binds to the free calcium ions. And if despite dietary restriction you're not able to get everything within control, you can start prescribing phosphate binders. But really, your management would be ideal if you could just manage the underlying cause, which is the chronic kidney disease, which is obviously difficult to manage. So going back to our clinical vignette, so we've got the first patient again who had a thyroidectomy due to thyroid cancer, muscle cramps and spasm, positive chopstick sign and positive trousseau sign. Now we can tell because the nurse reported spasms of her hand while checking her vitals. Suspected diagnosis, I hope everyone's aware. This one would be hypoparathyroidism. What tests we would order? PTH, calcium, excuse me, parathyroid hormone, calcium, phosphate, magnesium. You can order a good set of using these. You can do an ECG as well. Keep in mind if the patient has any other symptoms of respiratory distress, depending on her calcium levels, you'd also make your seniors aware. You'd replace the calcium if it's less than 1.88. I really think things from there. Further during her inpatient journey, you could do imaging tests as well. The second, that's the tests and primary, that's primary management as well. Then the second patient is a 55-year-old woman complaining of generalized weakness and bone pain, frequent kidney stones and depression, started taking what we call Insena. So we think she may have hyperparathyroidism. We do pretty much the same tests as we would, and we'd also order a 24-hour urinary calcium. And if this patient is symptomatic and she's got primary, management would usually be surgical, and we'll make sure to replace the vitamin D prior to surgery. Any questions so far? It'd be very surprising if I've understood everything. Any question, I'm happy to answer. So I'm going to give you guys a few seconds again. Just see if we've understood everything. Understandably, hyperparathyroidism, I'd say, is more complex than hyperparathyroidism. So just take a moment, see if you've understood everything. Primary, secondary, tertiary, investigations, the signs, symptoms, the management. How are we doing for time? We're doing good. And keep in mind the familial hypocalciuric hypercalcemia as well. That's just a curveball you'll be thrown in hyperparathyroidism. So I take the silence as everyone's understood everything and really following on really well. Now, we're not done yet. So as you would on a acute take, you're almost done, you're ready to go home, you've just got like 20 minutes of your shift left, and the consultant just comes and asks you to see one more patient before you leave. So we're going to quickly run through this patient so we can go home at the end of the day. So this patient's a 62-year-old man. He's got prostate cancer, and he complains of severe fatigue when you take the history. He sounds confused. The son says he is confused. And on examination, he's also got dry mucous membranes. So similarly, we're going to be running through it, see what our suspected diagnosis is, what tests we'll order, and what the primary management is. So something else to keep in mind would be hypercalcemia of malignancy. So the three major mechanisms through which you get hypercalcemia of malignancy. The first one would be tumor secretion of parathyroid hormone-related peptide. This is something that would obviously, since it's parathyroid hormone-related peptide, again, self-explanatory from the name, it's going to increase your calcium levels, decrease your phosphate levels. But something to please keep in mind is this is not biochemically the same as parathyroid hormone. On your lab tests, when you order parathyroid hormone, it will come up as low. It is not the same as parathyroid hormone-related peptide. This is a separate test and needs to be ordered separately for you to test for this. The second one is osteolytic metastases with local release of cytokines, which really is basically bone degradation causing hypercalcemia. And the third one is tumor production of calcitriol, which again cause hypercalcemia because of increased intestinal absorption. So you can see in hypercalcemia malignancy, we sort of mimic the physiological manner in which we increase calcium levels. However, the main difference would be that this is not adherent to feedback mechanism, which is why it is causing the hypercalcemia. So the main cancers you see this with are breast cancer, lung cancer, bladder cancer, multiple myeloma, renal cell carcinoma, but you can see this with pretty much any cancer that's really spread. I've seen it with colorectal cancer as well. You can see it with prostate cancer as well. So patients usually come with severe symptoms. They present quite acutely as well. You can see patients with increased urination, increased thirst, which is why you'd have a patient who's quite dry. Patients will have constipation, patients would have confusion. And it's quite important to keep this in the back of your mind, hypercalcemia of malignancy, as a differential for patients who have known cancer and present with such symptoms. Also, depending on the clinical scenario and the history you take in the exam you do, patients might even present with hypercalcemia malignancy as the first sign of cancer, but that would obviously be quite low down your differential, is not as likely as other diagnoses. So as for your investigation, you do pretty much the same thing as you would for hyperparathyroidism, except here's the big one. Parathyroid hormone-related peptide is something you'd also be testing for. As with hypercalcemia, your main treatment is going to be IV fluids. So it can be up to a bag every 4 to 6 hours, and you keep giving them bags of fluids and checking their calcium levels. Following that, you would give bisphosphonates to reduce calcium levels. Depending on your trust, you may need to speak to other teams to organize this. And again, for severe resistant cases, you definitely have to escalate and speak to other teams. The absolute treatment is to treat the underlying cause, which over here would be the malignancy, which again can prove to be quite challenging. So it usually ends up being IV fluids and bisphosphonates. And that's for hypercalcemia malignancy. So that runs us past the clinical vignette as well. So there's a man who's got prostate cancer, severe fatigue, sign of hypercalcemia, confusion that comes with the psychiatric overtones, and he's got dry mucous membranes because you get increased urine output as well with high calcium. So that's our suspected diagnoses. We've run through our tests, and the primary management would be IV fluids. Hope that makes sense. Once again, any questions at all, feel free to drop them in the chat, and feel free to fill the feedback form. Well, we've done quite well with time. We've got 20 minutes left. So anything at all, guys, feel free to let me know. Otherwise, thank you so much for joining the session, and we'll run our next endocrinology session in about a month's time, I believe. Primary, secondary, and tertiary. Yeah, yes, of course. So can you go with phosphate again? Primary, secondary, and tertiary hyperparathyroidism. So I just open the slide. Am I going the right way? There we go. That's the phosphate levels. This is the slide. I think you should be able to see it now. Blood results in, oh, yeah, hyperparathyroidism. So your phosphate levels throughout would be low in primary, secondary, and tertiary hyperparathyroidism. And in hypoparathyroidism, you'd see a high phosphate level. Oh, it's just, it's hard to, how do I, yeah. It's then the question, why is phosphate really low in secondary? So why is phosphate really low in secondary hyperparathyroidism? It's a very good question. I wouldn't be able to tell you the exact reason, to be very honest, and the exact pathophysiology behind it. From what I understand, your renal function is already quite poor in it, and whatever phosphate you do have is being bound to free calcium and then being excreted as well. So that pushes down your phosphate more and more in secondary hyperparathyroidism. Also keep in mind you've got renal failure in secondary hyperparathyroidism, which would run your phosphate levels down. I'm trying to share the, there you go. Any other questions at all? All right, I'll give you guys another minute or so. Regardless, thank you everyone for attending the session. Yeah, it's there in the chat now. I really appreciate if you could fill the feedback form. It shouldn't take more than a couple of minutes. And you should be getting a certificate at the end of it as well. Thank you so much for attending. Let me stop. All right, thank you everyone.